Okay, so I'm gonna share my screen. Yeah, as I promised, today I'm going to discuss about heart failure and acute coronary syndrome. So in here, so usually we all know about the therapeutic guideline, right? Do I need to do some explanation about therapeutic guideline? What is it, kind of thing? If you have any doubt or anything, like you can just ask or type in the chat, okay? So in Australia, there's one message. Yeah, okay. Yeah, doctor. In Australia, the therapeutic guideline is the one.
Там внизу option бар,
Sorry,
почтовые,
sorry,
музыка
I'm not
добавили
clear,
где-то.
doctor. Can you repeat it? Your voice.
Не, вот у меня у инструктора достаточно.
Doctor, you are asking something from me, or just can you mute your mic? Otherwise, it's gonna be like how to do the session. Thank you so much. So this is the therapeutic guideline. Okay, therapeutic guideline is the one, the one guideline, the updated one the Australian doctors are using. Usually, the Australian registered doctors has the free access to therapeutic guideline. And otherwise, other doctors mean the overseas. So any other doctors, we can purchase therapeutic guideline, but it is very expensive. I already have the access, so that's why I'm sharing the files and everything in the group. Then everyone can access it. So therapeutic guideline usually for the medicine part and some small topic, a small amount of topics in surgery as well. So yeah, this is the therapeutic guideline. So I'm just focusing the therapeutic guideline today, heart failure. Okay. So here, what is heart failure? Can anyone tell? Like we can do this like a discussion kind of thing, right? If you are interested. Otherwise, you are going to be like bored kind of thing. Okay, so here, who can tell me what is heart failure? What's the definition of the heart failure? Okay, no one is here. Okay, I'll explain. So, heart failure is a complex syndrome which is structural or functional impairment of the heart that can reduce the ventricular filling or ejection of the blood. Okay, this is like they are like explaining more in here, but I have like compiled all my notes that easily can access from the guideline. Okay, this is my note. Yeah, okay. So I have made this note from the therapeutic guideline. I have included everything. So here the definition. Usually the failure of heart to maintain the adequate cardiac output. Okay. Classically, this is mean the less than heart failure ejection fraction is less than 40%. Okay. And another one is ejection fraction can be preserved as well. Okay, the heart failure usually mainly we are divided into the reduced ejection fraction and the preserved ejection fraction. Okay, so and when we are talking about the heart failure classification, it would be like a huge classification, right? But for the AMC, we just need to know only this classification right in here. Okay, so here heart failure with reduced ejection fraction. That mean
Ma'am,
yeah, doctor.
uh, can you please explain HFrEF and HFpEF, both the different types, radius and the other one? Can you please explain it shortly?
Yeah, sure. Here I'm gonna explain it.
Thank you.
Here heart failure HFrEF mean here the reduced one, heart failure with reduced ejection fraction. Okay, heart failure with reduced ejection fraction. That mean the ejection fraction of the heart is less than or equal to 40%. Okay, remember this point 40. 40 is the number for reduced ejection fraction. Less than 40, that means the reduced ejection fraction. The second one, heart failure with mildly reduced ejection fraction. Here you can see the MR, right? That means heart failure with mildly reduced ejection fraction. That means the ejection fraction of the heart is between 41 to 49%. Okay, that called a mildly reduced ejection fraction. Don't afraid of these words, okay, these letters. Just remember R, MR, and P. Okay, the last one is kind of good one in here. Like prognosis is very good in this one. The last one, heart failure with preserved ejection fraction. Okay, that means the ejection fraction of this patient is more than or equal to 50%. Remember these three. This is the main classification they have mentioned in the therapeutic guideline. Okay, this is the main classification they have. You have to remember mainly. Usually, in MC exam, they are more focusing on these reduced one. Okay, I'll explain later everything in below of the file. Okay, so here. What are the causes of the common causes for the heart failure? Usually it can be ischemic heart disease, hypertension, valvular diseases like aortic stenosis, mitral regurgitation, and atrial fibrillation, cardiomyopathies like viral, alcoholic, or sometimes could be postpartum cardiomyopathies, and medication induced like NSAID induced kind of heart failure can be seen, but mainly usually it's more related with the ischemic heart disease and arrhythmia and hypertension and valvular disease. Okay. And there's another classification according to the NYHA classification. This is the American one. I just added for the references. That's all. They haven't asked, but in the e-medicine they have asked about this one as well. So I'm going to quickly go through it one on this classification as well, because from August exam they have given direct question from the e-medicine. That's why I have included this one, because I was doing the e-medicine. They have asked about the which kind of NYHA classification is 1 or 2 or 3 kind of thing. Okay, so you should remember this one as well. So here, one is NYHA classification. One is there's no limitation of physical activities. Ordinary activities does not cause any symptom. Usually the patient is just normal. Okay, there's no limitation physical activities. You should remember the patient is normal. In here, the second one is the second class. There's a mild limitation. Okay, mild limitation of the physical activities, but comfortable at rest. Okay, and some ordinary activities cause fatigue or shortness of breath. Okay, remember. And the third one, very easy. There's a marked limitation of physical activities and comfortable at rest, and less than ordinary activity causes symptoms. Okay, remember these points. Usually in units they are asking about the 2 and 3. So just remember some few points how to differentiate these two as well. Okay, and the fourth one is symptom at rest. Just very simple. The first one, there's no symptoms. The last one is, the fourth one is symptoms at rest. You have to differentiate only these 2 and 3, right? In the 2 there's a mild limitations, and the ordinary activity causes fatigue and breathlessness. In the class 3 there's a marked limitation, and less than ordinary activity causes symptoms. Okay, remember like this. Okay, so and we know this thing like acute heart failure. It can suddenly sometimes can be a heart failure. Okay, from pulmonary edema or some acute congestion kind of thing that can also cause acute heart failure. And the chronic heart failure, usually in elderly patient, they have persistent symptoms and so slow progression like that. And the other one is the we have differentiate these two as well. Okay, left-sided heart failure and right-sided heart failure. Usually left-sided heart failure. Okay, I'll show a diagram, then you can easily remember these things. You all can see my screen, right? If you want to
Yes, yes, yes.
zoom in, yeah,
No, it's okay.
yeah, okay, I'll bit zoom in, then it will be very easy. So here you just have to remember right and left features, okay, mainly, and that's better if you can remember how it's okay as well. Okay, so in here left one, we all know, right? In here, usually due to the hypertension or coronary artery disease and some valvular disease, these are the main things that can affect for the left-sided heart failure. Okay, and here the main thing you have to remember is pulmonary congestion. Okay, pulmonary congestion you have to remember. I'm not going to explain the pathophysiology because then it will be so boring, right? So just remember, I know everyone is know about the pathophysiology because you all already learned about it. So here remember the pulmonary congestion is a main thing you have to remember. That can cause cough, crackles like pink kind of sputum and tachypnea, tachycardia, fatigue, cyanosis, exertional dyspnea. Okay, so then we'll move to the right-sided heart failure. Usually that can cause by the left ventricular failure. Okay, usually this is this occur after as a secondary form to the left ventricular failure. Okay, and right MI or pulmonary hypertension can be cause right-sided heart failure. In here, you can mainly see the ascites and enlarged liver, hepatomegaly, splenomegaly, and the peripheral edema, jugular venous distension, and weight gain, increased peripheral venous pressure. These are the main things you can see in these two types of heart failure. Okay, yeah, you should remember these things. Okay, I'll move to the next part. So investigation. Okay. So investigation always there is a heart failure signs. You should do the transthoracic echocardiogram is the as a first line treatment. Everyone know about AMC, right? They are usually asked what is the first line, what is the most appropriate one, what is next best step. Like that, we should be more familiar with the question what they have asked. Sometimes we can understand the whole scenario and full question and everything, but in the end of the question we can't understand what they are asking, what is best one, what is most appropriate one, right? What is first line kind of thing. We should be more focusing with these words as well. Okay, when you are doing the MCQs and the recalls, you will be more familiar with that, so don't worry. Here, the transthoracic echocardiogram is the preferred investigation for patient with the suspected heart failure. Remember, okay, these are directly from the this one here, from the therapeutic guideline. You all can see, right? Directly. They have directly mentioned, usually MC taking questions from this one. This is because this is the updated guideline using in Australia. Okay. So here, and they have mentioned it provide the diagnostic quantification of the left ventricular systolic and diastolic function, including the ejection fraction, estimated filling pressure, and valvular function as well. And we had to do other investigations like ECG, chest X-ray, and blood, and BNP as well. So usually I'll explain the BNP part later because we need BNP in the later stage later. Okay, so here let's move to the treatment. Okay, I'm gonna explain firstly treatment for the heart failure with reduced ejection fraction. You all remember, right? What is reduced ejection fraction? Please type in the chat. Come on, doctors. You have to be more active. Okay. No one here to. Oh, you can unmute and tell. Okay, yeah, that's okay. If you are interacting more, then you will remember like a pro. Okay, yeah, like that. Okay, so here is the treatment plan they have mentioned in the therapeutic guideline. Okay, I'll show it as well. Okay, not in here. Okay, heart. We have to follow this guideline only. Okay, for the heart failure. Okay, here they are. I will show the questions as well. They are mainly asking from this part. Okay, you have like, please, if you can't remember these things, and please write it and make notes and do something to remember this one, because this is a very high topic for MC. Okay, if you really want to like, uh, please mark somewhere. This is very high. Okay, so I'm gonna explain this. Okay, here. So, how we approach for the heart failure with reduced ejection fraction. Remember the word reduce. Okay, less than 40. Okay, so here they have mentioned all patients with heart failure with reduced ejection fraction should be prescribed. Okay, prescribed four kind of drug. All patients should prescribe these four kind of drug. Okay, four main category of drug. What are those? RNAs, OACE inhibitors, and beta blockers. So the second one is beta blockers. Then other one is MRA and SGLT2 inhibitors. Okay. What are the four drugs? Can someone tell? Can someone unmute and tell me? Okay. So the
ARNIs,
yes.
AIs, beta blockers, MRAs, and SLG2 inhibitors.
Yeah, very good, doctor. Yeah, okay. So here you should remember in TG they have mentioned RNAs. You all know, right? What are the RNAs? They're like sacubitril, right? That is the main drug. And AC inhibitors, you all know. And here, remember the another drug is ARB as well. Okay, in the question sometimes they have given AC inhibitor. Remember like this first drug category. Okay, RNAs, ACE inhibitors, and ARBs. This is the first category of the drugs. Okay, and the second one, heart failure specific beta blockers. What are the heart failure specific beta blockers? Can anyone tell? Come on, doctors.
Maybe digitoxin and stuff.
What? I didn't hear you properly.
Digitoxin, maybe. I'm not
Yeah, I'm asking about the two types of mainly using heart failure specific beta blockers. That means the cardiovascular specific beta blockers. There's two types, right?
Bisoprolol, carvedilol.
Yeah, bisoprolol and the metoprolol. Remember these two drugs like MB. Remember MB for heart, like that. Okay, heart MB. Okay, remember MB for heart. That is metoprolol and bisoprolol. Remember, this is the second category of drug. Okay. Now the third category of drug is MRA. That means mineralocorticoid receptor antagonist. Okay. Write down these drugs, okay? First one is RNAs, ACE inhibitors, or ARBs. The second one, heart failure specific beta blockers, or we can call it cardioselective beta blockers. Okay, these are MB drugs, metoprolol, bisoprolol. Okay, the third drug is MRA, mineralocorticoid receptor antagonist. That means spironolactone or eplerenone. Okay, spironolactone or eplerenone. Okay, the fourth category is SGL2 inhibitors. You can remember it has empagliflozin or dapagliflozin, right? Okay, so there's any, yeah, doctor. Okay, so remember these four drugs, okay? Okay, with these four drugs, okay? So, okay. Do I need to repeat it again? If you want, I
No,
can
it's
repeat.
okay.
Yeah, okay. So you have to anyway like by heart remember these four drugs category. Okay. So here, anyway, for any patient with heart failure with reduced ejection fraction, we should consider these four drugs. Okay, four drugs category. But there's a one point you should remember. Okay, okay, we will go. Uh, down in this chart. Okay, so patient education, exercise training, and multidisciplinary heart failure management. Okay, heart failure management is like a multidisciplinary, right? We all know about it. Okay, then we have to consider the patient is congested or euvolemic. What does mean congested or euvolemic? Okay, there's a heart failure patient. Okay, you did the echocardiogram and you suspect heart failure. Then you did the echocardiogram. Okay, then we have to decide the treatment plan. We decided other things like exercise planning, diet, and everything. Now we are in the situation how to decide the drug categories. Okay, we know we should give these four drugs. Then how we should give these four drugs? We have to consider one more thing, right? Okay, there's acute symptoms, shortness. Yeah, doctor. Features of overload. Right, you are correct. So congested mean there's a fluid overload there. Okay, congested. As you remember, I have mentioned in the left-sided heart failure as well. There's a congestion, fluid overload, right? Fluid overload. What are the symptoms with the congested heart failure, congested patients? There is a fluid accumulation in the lungs and there's a cough, crackles, wheezing kind of things you can see in the congested patients, right? Okay. Now our patient is congested. How we treat our patient? Okay, if the patient is congested, we can't give beta blockers. Okay, remember this point. If the patient is congested, we can't give beta blockers, but we have to give other three drugs. Okay, we have to give other three drugs. Okay, that means we can give RNAs or AC inhibitors or ARBs plus MRA plus SGLT2 inhibitor. We are giving three drugs here because our patient is congested. Our patient has a fluid overload. So we are not giving beta blockers here. Okay. So this is like exclusion for the main treatment if the patient is congested. Remember this point. Okay. Okay, then one euvolemic. Okay, then after this treatment, our patient is back to normal, normal. There's no fluid overload. Okay, after being normal, after being euvolemic, then we have to add beta blockers. Okay, here, then once euvolemic, add heart failure specific beta blockers. Okay, remember, uh, if you want to give beta blockers for the heart failure patient, you should consider the patient's fluid level. He is congested or not. Okay, I think hope you all get a proper idea about it. Did you understand, doctor? This part?
What's the reason of introducing beta blockers later into the treatment plan?
Because in here, when we give the beta blockers, when we give beta blockers in congested patients, that beta blockers like that can reduce the heart rate and everything. It can lead to the kind of hypertension and it can lead to the shock as well. That's why we are not giving the beta blockers in this kind of patient. Okay. Here they remember this part in here. So euvolemic patient, another patient. This one is our patient A. Okay, A patient with the congested features. Our B patient without congested features, but he has other all heart failure features. Okay, so here now the patient is euvolemic. Now we can give all 4 drugs. Okay, all 4 drugs. We should start all 4 drugs together here. RNAs, OAC inhibitors, or ARBs. This is the first category. On then second category, heart failure specific beta blockers we should give. Then MRA third category, and the SGLT2 inhibitors fourth category. We should give all 4 drugs in euvolemic patients, right? Yeah. Okay, so here. Hope you all get a proper idea about the congested patient and euvolemic patient. Okay, then you should give this treatment if it is at the diagnosis or here within 2 to 4 weeks. Same. If at diagnosis, so within 2 to 4 weeks. Okay, and here we have to start or continue an uptitrate of RNAs, OAC inhibitors, and beta blockers every 2 to 4 weeks to the target or maximum tolerated dose. Okay, and MRA can be uptitrate 4 to 8 weeks if required. Don't like think about this. Sorry, don't think that much about this part. Just remember we have to continue this drug to their maximum tolerated dose. Okay, then aim to achieve the target or maximum tolerated dose of the all drugs within 2 to 3 months. If the patient has a good prognosis, after 2 to 3 months, patient, the target is, or the maximum tolerated dose should be within 2 to 3 months. Remember 2 to 3 months as well. Okay, then after 3 months, we should repeat the echocardiograms to check whether the ejection fraction and other parameters as well. Okay, to check the is there any prognosis or not. Okay, and remember this point. Okay, this point. Please remember this point. Because in the November exam also they have asked about this point. What is there? There's a question. Euvolemic patient is characteristic by what symptoms as is congested? There's a fluid. Doctor, in the euvolemic patient, there's no congested features. Do you remember I showed in the previous here the picture? The congestion features like cough, crackles, pink sputum, these kind of things like pulmonary congestion. Okay, remember these symptoms. Okay, these are the congested symptoms. And okay, so here remember this point. We should repeat the echocardiograms after 3 months. After 3 months of the treatment, within 3 to 6 months, because we have to check whether our therapies worked or not. Okay, and remember this point because in the I think they are repeatedly asking this point. Okay, I'm gonna read it. If not on RNAs, okay, if not on RNAs, and the left ventricular ejection fraction is still less than 40 or equal to 40, we should change ACE inhibitor to RNAs. Remember, this RNA is like a miraculous drug in heart failure. Okay, because AMC is more focusing on this. We don't know why they are focusing on this part, but they are focusing on this part like recently. Because in the November also they have given one question. I'll send it in the chat. Later I couldn't find it, but I have remembered this question. Okay, so yeah, then after consider the drug. Yeah, this is how we should manage the heart failure with reduced ejection fraction. I know this is hard, okay? This is hard, but you should be like more focused and you have to revise it again and again. Then it will be very easy for you. So the main thing for IMS is you should revise everything, okay? Yeah, okay. Then I have simply explained here as well. Okay, all patients with should receive for foundation medications and plus education and everything. Just the same thing. Okay, I have explained it here as well. Okay, congested patients pathway. At the diagnosis, so within 2 to 4 weeks, start RNAs, OAC inhibitors, then start MRA, and start SGLT2 inhibitors. Congested patient, remember three drugs, okay? Here, do not start beta blockers yet because the patient is congested, okay? Once the congestion is resolved, that means the patient is euvolemic, then you can add heart failure specific beta blockers like metoprolol, bisoprolol. Okay. Okay, the same thing. Then euvolemic patient we have discussed. Okay, and this is the part I told you, okay, and they have asked this part as well in the past records. So how we monitor heart failure usually. Repeated echocardiogram in 3 to 6 months to check ejection fraction response, okay, and the same thing. And one more thing I have to tell. Yeah, this question. Okay, this kind of question. This is the images question, and in the November exam, they have given the same kind of question as in the exam as well. I told you recently they have more focus with the e-medicine because they have a partnership with e-medicine. Actually, it's better to go with like parallelly with e-medicine. Okay. Do you guys already booked the exam?
No, not yet.
Not yet, right? If you're like, yeah, if you're going to book the exam, and like, please buy the e-medicine because don't do Amadex, Mplax or anything, just only e-medicine, okay? They have started a new pattern on from August. I'll do the recall sessions as well. Then you can see the doctors have sent the exact question from e-medicine, and they have sent the picture. Okay, that's how they are like they are promoting their e-medicine. Okay, so we have to buy and do the e-medicine. I have the PDF one, and I can share in the group as well. But please don't outside, otherwise there is a copyright things, and you know that in Australia there will be like problem. I'll share it, but please don't share outside the group. Okay, there's a screenshot PDF I have.
Doctor, I have one question.
Yeah, doctor.
Yeah, doctor, which this summarized file you make your own notes, can we have access in the file section? Is it available? Because it's a very precise summary of the TG guideline topics. You have done very good job.
Yeah, these are like new files, doctor. Even I also use a TG, downloaded TG file, and I just highlighted. That's why the TG is like very, very like comfortable zone for me. I used to read every word in the TG, and now I know no one like to read the TG. That's why I have made, but I don't have like everything. But I'm trying to make some notes. Yeah, let's see, doctors. I'm just like starting this making notes as well. Yeah. Okay. Let's see. Yesterday, files I have shared the pertussis and pneumothorax from the TG and the RCH guideline. You can check in the group, but these files today I just make these two files just for the today's lesson. Okay. So here there's a question. Okay, we will do it together. Then you will give me the answer. Okay. A 65-year-old man presented to the GP clinic for follow-up after recent hospital admission for heart failure. He has a medical history of hypertension and type 2 diabetes. His current medication include bisoprolol, condensate, furosemide, dapagliflozin, and spironolactone. His most recent echocardiogram shows the left ventricular ejection fraction less than 35%. On examination, he appears well. His pulse rate is 72 and the blood pressure is 110 by 80. Respiratory rate is 16. SpO2 95. Temperature is normal. He report improvement since discharge but still has SOB with moderate exertion. There is no peripheral edema and his chest is clear to auscultation. His estimated GFR is 45 and the serum potassium is 4.2. Okay, then it's decided that one of his medications should be replaced by another agent to improve his long-term prognosis. So, which one of the following medication would provide the greatest mortality benefit? Digoxin, ivermectin, sacubitril valsartan, hydrolysine. What do you think, doctors? Okay, our patient is already in bisoprolol, mean he is on beta blockers, condensate, that mean ARBs. So furosemide, I think he has a congested failure, and they have given the furosemide as well, and the SGLT2 inhibitors and the spironolactone as well, MRA. So, and still his ejection fraction is 35. Do you remember the point that I have like pointed before? Remember?
Yeah.
Yeah.
When there is no there is no any improvements, we should to switch to the ARNIs.
Yes. Right? You can see, right? They are directly asking from the therapeutic guideline. Here, if not on our knees, and left ventricular ejection fraction is less than or equal to 40%, so we should change ACE inhibitor or ARB to ARNIs, right? Okay, this is how they are focusing, they are like tricking us on the examination. So here, sacubitril valsartan. So here, this is the answer. Okay, hope you all get a proper idea, right? I just added for the references from the e-medicine. Yeah, here I have mentioned it as well. Okay, the same thing. Okay, e-medicine explanation as well. They have mentioned sacubitril valsartan provide greater mortality reduction than ACE inhibitors or ARBs in heart failures, reduce ejection fraction. So this is disease modifying therapy in heart failure with reduced ejection fraction should include sacubitril valsartan, beta blockers, MRA, and SGC2 inhibitors when tolerated. Okay, the 4 drugs, ivermectin and digoxin, reduce the heart failure. Admission is selected patient, but okay, I will explain that part here. Okay, then another this is the next part. They are asking in the heart failure. Okay, when we are treating the patient with these 4 drugs in reduced ejection fraction, we can expect these changes. Okay, sometimes there can be a mild drop in blood pressure. Okay, hypotension. Then kidney problems like creatinine may be rise up to 30%. Remember these points, okay? Then potassium may be rise but stay in normal range. Remember, hypotension, increase creatinine level, then potassium level also increase. These are the main 3 things that we can see in these patients. Okay, so here I'll show the Okay, here, this part I have like summarized in here, okay? Symptomatic hypertension, kidney functions, because they are directly asking from this part as well. I have already shared the therapeutic guideline PDF in the chat. You can go and read that as well if you want, okay? So symptomatic hypotension, okay? Here the if the patient got symptomatic hypotension while on for drug therapy, okay, for drug therapy, and now patient got symptomatic hypotension. First, we have to do the we can split the dose as morning or night, like that. Then we can review volume, status, and other medication. Then stop non-essential blood pressure lowering drug. If the patient is already taking another drug for his blood hypertension, we can consider of stopping those drugs. If it's still symptomatic and not congested, it's still symptomatic but not congested. Okay, that means patient is euvolemic. There's no congestion. We can reduce ACE inhibitors, ARBs, or RNA, or other vasodilators. Okay, and we can reduce loop diuretics like furosemide, and we have to keep beta blockers unless the heart rate is less than 50. We can if the patient is not congested, we are not stopping the beta blockers, okay, because beta blockers like a very good drug for heart failure patients without congestion, okay. They are not asking from this part. Usually they are I'm just like explaining because sometimes they can ask from this part as well, okay. Remember, just give it a read, then no need to like thoroughly memorize this thing. But here, these two these two mean the hyperkalemia one. You have to remember thoroughly, okay. Here the second one is the kidney function worsening, and the creatinine level is rise, okay. Then first we have to check the volume, okay. Volume, if there is no congestion, okay, if there's no congestion, we have to reduce the loop diuretics, okay. We can reduce the loop diuretic because usually we are giving loop diuretic like furosemide for if there's a congestion only, right? Otherwise, we are not adding the furosemide for the patients, okay. And so if the patient is no congestion and the patient creatinine level is increasing, we can stop the loop diuretic. And if the patient is taking NSAID for pain or any other medication, we should stop NSAID, okay, because NSAID, we are not giving NSAID for the patient with the kidney problems. Okay, remember this part because in the gout, they are mainly focusing on that part as well. I'll explain it in gout lesson. Okay, and they consider reducing these drugs as well. Just give it a read, okay. I know it's very hard to remember this kind of thing in the day one, even for me also. When I'm learning this heart failure thing, it would be like it was very hard for me. Then after reading one by one every point, then I realized and I did the question. That's how I get a proper idea. Okay, here the another adverse effect in the heart failure patients while in this for drug therapy, hyperkalemia, okay. So if the patient develop the hyperkalemia, first we should ask the patient if whether patient is taking potassium supplements or anything, okay. If patient is taking some potassium supplement, we should stop it, okay. Then we should review the diet, and we can reduce the ACE inhibitors, ACE inhibitor, AR, RNAs, or MRA. If if potassium level is more than 5, we should stop the MRA spironolactone. Remember this point. If they are asking something related to hyperkalemia, what drug we should stop first? Go with spironolactone, okay. Don't think twice because this question is they are usually asking in the MC exam. This question. So what is the like adverse effect from the hyperkalemia? Can someone tell what hyperkalemia can be caused? Yes, arrhythmia. So that's what, if the potassium level is increasing, we should consider about the drugs. Mainly the first one is, number one is spironolactone. Remember this, okay? And sometimes the patient with the heart failure, they can develop the iron deficiency anemia. So here in the TG they have mentioned heart failure, and the patient with heart failure and anemia, we have to give IV iron. Remember, IV iron, okay? IV, not oral, IV iron. Remember this point as well. IV iron, okay? Yeah. Yeah. Okay. So we are done with the heart failure with reduced ejection fraction. Do you have any problems regarding this topic? I know it's hard for like uh, doctors who are preparing from like from the scratch. Yeah, this is, I think, first time. Yeah. Yeah, thank you, doctor. If you have any problem, just ask, okay? I'm not gonna eat you. You can unmute the mic and we can do like friendly conversation, okay? Don't afraid or anything. We can just like do friendly conversation. I really like if we can unmute your mic and then we have like a conversation. When I was doing the recall sessions also, I usually ask the other doctors to be like active in the sessions as well, because that would be like very funny and you can like enjoy while doing the session. Okay, so the next one, this is a very simple part. They are not usually asking from this part. This is like a very simple one. Heart failure with preserved ejection fraction. I already mentioned. Okay, there's a one message. Yeah, thank you, doctor. Yeah, you should never be frightened. Okay. Yeah. Okay, we will cover MC like properly. Don't worry. I'll help. And so here, heart failure with preserved ejection fraction. Preserved. What is preserved? Who can tell me? Okay, just type in the chat. You don't have to worry. Just type in the chat. Preserved ejection fraction. What is preserved? Preserved means, doctor, more than 50. 41 to 49 mean mildly reduced. Preserved means like more than 50. Okay, yeah, it's okay, doctor. It's okay, now you can remember. If you are doing mistake, that's the best thing in the future. You can remember, okay, I did this mistake and now I know, right? That's how I remember so much things. Okay. Okay, I have explained what is it, and here I have summarized it. Here the principles of management. Usually the preserved one, the ejection fraction is more than 50. Okay, you don't have like worry too much, right? So just from the in here, like we should diagnose and treat the cause. Usually, as example, hypertension. If the patient has the hypertension and this hypertension cause the heart failure, we can treat the hypertension like that, okay? And we have to assess for the infiltrative cardiomyopathy if the unexplained left ventricular thickening, example like amyloidosis, like that. Just forget it. They are not asking from this. Just treat the cause. That's it. The drug therapy is SGLT2 inhibitors, improve the cardiovascular outcomes. Like if the patient with the diabetics, and then we can control that one as well. Like they're in here, they are just telling the treat the cause and other comorbidity like that, okay? Just you don't have to thoroughly remember, just go with the flow. But in the reduced ejection fraction, you have to thoroughly remember, okay? Thoroughly remember. Please don't forget this chart. This chart is a life savior, okay? Life savior in exam. Please. Okay, so yeah, that's it for heart failure, doctors. Yeah. We took like 1 hour for the heart failure. I'll take a like 10 minutes break. Then we can continue acute coronary syndrome. Hope you all get a proper idea. Okay, that's good. No, doctor, this is not from the Murtagh. I'm actually telling don't follow Murtagh, just follow TG, okay? Yeah, okay. We will meet and after 10 minutes. Now my time is 10:25. Yeah, 35 I'll join.